I do want to talk about what I see as a really key both barrier to early and timely diagnoses, and also an opportunity. And this is something that Barry, you referred to, the annual wellness visit. So, somewhat surprisingly, we do not have a population screening program for cognitive impairment. We have it for many other things. We have it for breast cancers, many different kinds of cancers, high blood pressure, high cholesterol. We don't have that in the US. We do have a tool at our disposal. We have something called the annual wellness visit, which is a fully covered benefit for Medicare beneficiaries that includes or requires a cognitive screening. So this is potentially a really important step in getting everybody diagnosed and everyone diagnosed in a timely manner. But what happens is that not all Medicare beneficiaries get an annual wellness visit. It's about 50 to 75%. And again, these populations that we've been referring to as undiagnosed, underdiagnosed, less likely to have an annual wellness visit. And then when we look at persons in the US who had an annual wellness visit, only about a third report getting a cognitive assessment, even though that's a required component. So why is that? So here is where I think policy has an easy kind of alternative. So one of the reasons why people are not getting them is that although it's required, there's no guidance for physicians and primary care physicians on how to do the cognitive assessment, if it should be a standardized test. It may be as simple as, are you concerned with your memory? Okay, moving on. So that's a place where I think policy can impact assessment right away. Require some validated standardized tests that are culturally relevant for the populations that they're testing. And the other kind of part of this that I want to speak to, because I think Monique brought it up very importantly, is what happens in the healthcare practice and with physicians. So an annual wellness visit with a cognitive assessment and all the other screening they have to do takes a lot of time. And many practices are not set up to manage that kind of workflow and allow physicians that time. The populations that we're concerned that are underdiagnosed and diagnosed late, a lot of them get their healthcare from community and other types of, I would call sort of safety net or low-resourced healthcare systems. And physicians who work in these systems, they see a very high volume of patients. They don't have a lot of time. Their patients tend to have a lot of comorbid conditions that they're dealing with. We have a colleague here at USC, Elizabeth Joe, a neurologist, who just finished a study in a large safety net system and found that the diagnosis rate for dementia in the older population in a safety net system was 3%. National level is about 10%. So there's some serious underdiagnosing going on in these systems that is also kind of contributing to this underdiagnosis, underdetection that we think is real and we know is really important for producing real world evidence, getting people into trials, getting access to these new and novel treatments, as well as better detection methods. So I'm going to pause because I spoke for quite a bit and we're running low on time, and I have such great colleagues here that I'd love to hear more from.
Monique, would you like to follow up on Julie's comments before I chime in with some?
Yeah. So I think everything she said goes back to, and I'm so glad she did say these things, the system that we have created of how we deliver healthcare and how we practice healthcare. So community health centers, where a lot of under resourced people may seek care, like you were saying, or other types of safety net institutions. But in general, primary care physicians are allotted a small amount of time to see their patients, right? So like 15 minutes for a regular visit, 30 minutes for a physical, which is this annual well check visit that we're speaking about. And it's 30 minutes with what a lot of my colleagues in primary care have said to me is your future self, right? So 30 minutes of preventative discussions. We're going to talk about your colonoscopy. We're going to talk about all of these things. And usually you start with like a long, like big fat checklist that you fill out in the waiting room. And those are the screening tools, right? So are we really going to continue to support like the diagnosis of patients if we are not actually supporting the visits that these patients are able to get, right? Like all this cannot be accomplished in 30 minutes or 15 minutes. Or if you're brought in by your daughter who says, "Hey, I am worried about mom's memory," it's a 15-minute problem visit. And those are like standard amounts of time for primary care physicians to see their patients and do these things. Access to specialists, really, really difficult. Once you leave your primary care, who will say, "Great, you need to see a neurologist." Or if you see someone like me in a hospital, people often say, "Oh, thank goodness mom's in the hospital. Now we can see the neurologist. Now we can do all these things," because they feel like they have a captive audience at this time. And it's great. We'll see you in the hospital, but then you still have to make that appointment afterwards. And that problem hasn't changed. It's still the exact same. So how we fund the care determines the care that's going to be given. How we legislate or what we say are the tests that should be given. So we know the screening test for colon cancer is a colonoscopy. If we need to define the screening test for dementia as X, Y, and Z, let's do it. Let's make these clear definitions. Let's build these things into the infrastructure and give practitioners the support, the time, and the financial support to deliver the care.